Okay, so I think that it's time that we can start this webinar on Thursday, 7th of July. I'm very pleased to say good evening to everybody is connected. This is another important webinar organized by the ESSM Society together with the support of IBSA. Shall we start with the slides, please?
Sorry, I was having a little technical issue.
No problem. We are live, so we know things may happen. No trouble. Okay, we can move on. So this is another webinar with IBSA, and we have started this very interesting series last year together, and we have touched different topics, and we have very important speakers. And today, again, we are here with two very good, not only speakers, but friends, Silva and Giovanni. So I think that then Mikkel and Giovanni will introduce them. I don't know if we can move on with the slides, because if there is problem, Daniela, then we can do differently. Okay. So first of all, as usual, I need to make a big thank to these two persons, very hard workers for our society, and Giovanni, the Corona, who has been for some years the chairman of the scientific committee, and nowadays is the president-elect of the society, and he initialized this series of webinars with IBSA. And then Mikkel has been for a long time in another position in our society, but nowadays he is the chairman of the scientific committee, and so he is very well used to follow up all the scientific contents, and so I'm sure that he will do at best again this position in the next years for our societies. With regard of our educational projects, I'm very happy to really touch this point that is one of our best product is the ESSM School of Sexual Medicine that, as you know, we have double in a new course called ESSM Advanced Course of Sexual Medicine. We can tell you that we are scheduled in Budapest in November 18th to 27th, so everything is ready, and as far as I know, I think there are only a couple of seats still available, but basically we just fulfill all the possible positions to participate. And this is very important because we touch in a very easy way, a very, let's say, informal way, all the topics in the field of sexual medicine, not only clinician, but also the psychological one. If we think about also our certifications, you know that we started more than 10 years ago in Amsterdam with this exam, and we do every 2 years, and we do in cooperation with the European Federation of Sexology and the Multidisciplinary Sexual Medicine Committee that basically set up all of these important and complicated systems to give certification that are validated in Europe. And we do for fellow in the European Committee of Sexual Medicine on one side and on the psychosexologist on the other side. The date for the exam is fixed on the 22nd of April 2023, and the application now is open. So if you go on our website, you are able to join and to put your name on. We have already started another important educational program that is the Academy on Surgical on Genital Surgery. As I told you in other previous occasion, we have 3 different levels. Basically, we have already done the online webinars, we did 3, and also the textbook and the video library steps. Now we are able to start in September the last step, that is the 3D model and the fellowship in our centers of excellence, and we have already the people that has win this possibility, And so we are very happy to advise that this first year Surgical Academy is going to end up at the end of this year, and then we are now able to start with a new edition, and very soon in September you will find all this information again on our website. Just to tell you that our manual of sexual medicine is going very quickly to be completed in terms of update, and we hope next year really to finish all of these. And we are working also on the syllabus of clinical sexology. So all of these are really very important pieces, because we consider those books our Bible. And with regard of surgery, the textbook has been already prepared and then is already published, and we use a lot for our Surgical Academy. Is available again only for ESSM member on our society website. So just last bit for me to remember that we are ready to be there in February in Rotterdam, 16 to 18 of February. So be able to find the possibility for all of you to come over. I think we will come back physically since quite a long time, since about 3 years. And so I really look forward to see all of you next in this important event in Rotterdam. So I'm quite pleased now to leave, if we move on, yes, to Giovanni, really a few words to introduce this webinar, and then also to Mikkel. And thank you very much, and stay tuned with us. Thank you.
Thank you, Carlo. I think this is another great success of the ESSM. We have a lot of attendees from around the world. I saw from South Africa, South America, Asia, and so on. So again, another great success, and we need to thank IBSA for their support for this great webinar. As Carlo said, we have 2 outstanding speakers and a very hot topic. So thank you to be here and enjoy the show. And again, for sure, I'd like to invite you for Rotterdam. I hope that COVID situation will allow eventually to be in Rotterdam, and again, it would be a great success. Now it's time to give the words to Mikkel, who will introduce the speakers. So Mikkel, please.
Thank you very much, Giovanni. It's a pleasure for me to be here and be able to introduce a webinar on such a difficult topic, which is not spoken so much about, sexual abuse and sexual disorders. And again, we have to thank IBSA, our sponsor. Without IBSA, this would not be possible. And the first speaker for me to introduce is Silva Neves from the UK. He is a certified psychotherapist, a specialist in psychosexuality, and he works with trauma psychotherapy specifically and sexual abuse victims. He's also written several important books and chapters on the topic. So really a world expert we have with us tonight. And the next speaker, Giovanni Castellini, also a very prominent name within this field. He's a prominent researcher at the University of Florence within psychiatry and neuroscience. He has an MD, PhD with a very impressive and broad knowledge about psychiatry in general and this topic specifically. And he's authored approximately 200 papers about it. So I am very, very proud to be able to introduce 2 such excellent speakers for tonight's topic. We will have more webinars of the same quality, I am sure. Dates and topics will be announced on our website for the fall 2022. So stay tuned for that. And of course, as Giovanni and Carlo has mentioned, remember to join us in Rotterdam. But for tonight's webinar, the first speaker, Silva Neves, please.
Thank you very much, and thank you for inviting me. It's wonderful to connect with such an international crowd this evening. So let me just share my screen. Okay, can you see that?
Perfect.
So tonight I'm going to talk about the impact of childhood sexual abuse and rape in adulthood, the kind of overview about post-trauma symptoms, the most common ones, and also what we can do to help our clients or our patients who have common sexual dysfunction as a result of sexual abuse. So I was already introduced, I can go through that. First of all, let's just position sexual abuse within trauma in general. In traumatology, we say that we have 4 types of trauma that we identify as trauma. One of them is incidents that threaten a person's life or that is perceived as a threatening a person's life. The other is witnessing an act of violence. And the third is hearing or seeing the deaths of someone that's close to us. And the fourth is sexual abuse. So sexual abuse has its specific category because there are some specificities that I'm going to talk about in a minute that doesn't always, that are not always present in other traumas. So of course, some people with sexual abuse, they might also perceive that their life is a threat. They might experience an acts of violence, that's for sure. But there are also some specificities that happens in sexual abuse that might not happen in other trauma, say, for example, a car accident, and so on. So sexual abuse, when we think of sexual abuse, first we think of sexual abuse in childhood. That's unfortunately very common. Rape as in adulthood. So the way that we define rape currently is a penis entering a vagina or other parts of a body. So it's kind of like it needs a penis to have the definition of rape. But now we're trying to broaden the definition of rape that might mean anything that is breaching the integrity of somebody's body. Sexual harassment can be something that is non-touch. It could be online harassment. It can be making somebody feeling really uncomfortable or distressed in a sexual way. And it can also be stalking. And then sexual assault could be anything that is about, again, the body integrity being breached, but not necessarily penetration. So what is specific about sexual abuse that may not happen in other types of trauma is first secrecy. And that is one of the hallmarks of sexual abuse. And that is because a lot of the time people that have been sexually abused, whether it's children or adults, it's because there is a grooming process that happens. Most people, a great majority of people report being sexually abused by somebody that they know and somebody that they grew to like and even love. So then what that means is that when somebody that's supposed to love you is actually sexually abusing you, there is a great sense of secret, a great sense of shame, and a great sense of silence. The secret goes beyond just the person that is abusing you. It also goes into the areas of fearing not being believed by the police, because a lot of the time, if people report a sexual abuse that is over 7 days ago, it means that there might not be any evidence of the abuse, and so that can be easily dismissed by the police. And a lot of people are fearing that, they're fearing not being believed. And some, because of the grooming process, also fear that if they report, they will ruin the abuser's life. And a lot of the time, people might think, yes, my abuser did something very wrong and he needs to be reporting, but I also still have some emotional bond with that person. And that's very confusing. And as I was saying, also the shame and the guilt, a lot of the time, because of the grooming process, there will be some kind of narrative that will be implanted in the victim's mind. For example, some things like, you're the one who seduced me, you wanted it, I could tell you enjoyed it. And all of that, of course, creates a lot of shame, and people then start to be really, really confused about the sexual abuse and whether it's worth reporting. The next hallmark of sexual abuse is the breach of trust. Again, that's because usually the abuser is somebody that is known to the victim. And so what it means is that the kind of trauma and love is intertwined in a way that is really, really complex. And also because of the physiology that we have, a lot of the people report or remember feeling pleasure, sexual pleasure and arousal, even with unwanted touch. So when it's done with both by somebody who's supposed to love you, as well as feeling the physiological pleasure of the unwanted touch, it creates super complexities in how we're going to help the client or the patient untangle their trauma and making a story that is actually congruent with what did happen to them. So any sexual abuse is really, really complex for those reasons. The symptoms of PTS, so PTS is post-trauma stress and PTSD is post-trauma stress disorder. The difference between the two is that the disorder bit means that the person's symptoms are so significant that it stops people functioning in their lives. So they can't maintain relationships, they can't turn up to work, they can't even attend to their personal hygiene. That's the kind of like the disorder bit. But a lot of people will experience some really distressing post-trauma stress, but still being able to have some kind of life functioning. One of the main symptoms is what we call flashback, and that is basically involuntary memories of the abuse that comes back to that person, either by seeing something that is there, thinking it's happening in the here and now, although it is a memory. But those flashbacks can also be a flashback of a body memory, so feeling like they're being touched when they're not in the here and now. Or it could be something that they're hearing the abuser's voice, for example, even though the abuser is not around. So that's very, very distressing. Flashbacks are very distressing symptoms. The other one that's very common is dissociation. So that's when the body goes into shutdown and people just completely disconnect with whatever is happening. Sometimes dissociation can actually be quite functional because people then don't feel any pain when they're in dissociation. But of course, some people sometimes can dissociate while they're driving, for example, and that can be very dangerous. Hypervigilance, meaning that people will scan the environment on a constant basis for threat, and they, if they have been abused on a regular basis for quite a long time, they might have developed a worldview of mistrusting the world, not trusting anybody. Low self-esteem, self-hatred, and depression that internalizing some negative core messages about I am wrong, this happened to me, but it's my fault, I shouldn't have not been seductive, all that stuff that the grooming process gets those people to internalize negative beliefs, as well as feeling guilty. And re-victimization, it is often when people, especially for childhood sexual abuse, often if it happened in childhood, it means that people don't get a sense of what is right and what is wrong in a relationship, what constitutes a good relationship compared to an abusive one and a toxic one. So often people will, in adults' life, go into relationships that are not good for them and relationships that are abusive because that's all they know. And all of that, of course, the last symptom is sexual and intimacy problems, of course. So when people are traumatized at the moment of trauma, there are two things that happen in the brain, and there's many things that happen in the brain, but two things I'd like you to think about today. The first is the time processing part of the brain switches off, and also the speech area of the brain switches off. So that's important because this is what creates flashback, basically. A flashback is a memory that's floating around, but because there's no time processing, no time stamp on that memory, it reemerges as though it's happening in the here and now. So part of the trauma treatment is to help the brain reconnect with the story that says that trauma event happened how many years ago and it finished. It's not happening now. So it's about reconnecting the trauma processing part of the brain to the trauma story. And the speech one is important to remember too, because if you get people that starts to talk about the trauma and suddenly you notice that they're stuttering, or you're noticing that they just go like, and they can't formulate words anymore, it means that they are actually getting re-traumatized because they're going into the part of the trauma that has no speech attached to it. So again, if that happens with your clients, it's important to stop them, slow them down, and go back to an area of their memory where they can access speech. Somatic markers is also something important to know about trauma. It's basically all of our senses that we have that could remind somebody of a trauma. So those things are, the somatic markers are the markers that are embedded in memories. So some people, if they see something that reminds them of their trauma, they can suddenly have a flashback coming straight away. For other people, it's smelling something or a particular touch, a particular sound, a particular taste, and sense of your orientation. For some people, it's actually lying down on a bed. That's the orientation of lying down could actually remind people of a trauma if the trauma happened when they were lying down on a bed. So, and of course, that's problematic if you want to have sex. The good news about somatic markers is that it works the opposite way too. It works with positive memory. So we can access and ground people with positive memories through the same senses. So if they look at something that reminds them of a positive memory, their nervous system can slow down and can go into a state of calm. So a reminder of a traumatic memory, the nervous system can dysregulate, but a reminder of a positive memory, the nervous system can calm down. The trauma response, the typical one is, and I'm sure we know that already, is the fight, the flight, the freeze, and the fawn. So fight is when the body prepares itself to fight against the threat. Flight, run away from the threat. Freeze, the body is preparing to not feel anything, to not feel the pain. And fawn is about appeasing the abuser so that there's no more conflict. And the fawn one is the one that can be problematic in relationships, for example, because if they're in a relationship that's not so good, because they're trying to appease the partner that is breaching the boundaries, it might mean that they might not find their own voice, or they might not be assertive enough to ask of their partner what is right for them. If people go into a flight or fight, it's basically a system that is based on the threat center. So when people are in that situation, they are not going to be able to be sexually ready, because we can't actually prepare our body to have sex at the same time as preparing our body for threat. Those are two different systems. So when people go into a sexual situation and the sexual situation reminds them of a trauma and they go to either fight or flight, they are just not going to be, they are more likely to have sexual dysfunction. And explaining that to patients is really, really helpful because it normalizes their processes. And of course, the freeze is the one when people just might not feel the touch. So often people might report saying, oh yeah, my partner touched me. I knew my partner was a good partner, is not my abuser, but I just didn't feel anything. And that might mean because they might mean they're in a freeze state. So the sexual and relational problems that comes out of sexual abuse are basically all the common psychosexual problems that we see every day in clinics, even those that don't have any trauma. Vaginismus, of course, is the protection against previous breaches of bodily integrity. It means nobody goes there, that's it. And so that's highly related to sexual abuse. Dyspareunia is pain in penetration, and often that could be a memory of pain rather than an actual real pain. So that's something to investigate. Inhibited sexual desire is basically the flight response. It's the sexual desire getting out of the room so that then there's no possibility for sex. If there's no possibility for sex, there's no threat. Anorgasmia is usually when people have experienced sexual pleasure during the time of the abuse, and because it's so confusing, the body has used a strategy to stop feeling orgasm because it's less distressing for the person. So all of those things, although they are sexual dysfunction, they are also actually helping the person get on with life, avoiding their trauma symptoms, which means that they might not go into trauma response all the time. So even though it's a dysfunction, it's important to look at the function of it. The same happens with the male presentations of erectile dysfunction or unreliable erections. As I said earlier, if your body goes into fight or flight, your body is not going to go into sexual arousal. So it's almost the absence of erection when you're in fight or flight is actually functional and congruent to what your nervous system is doing at the time. Rapid ejaculation is probably the one that's the least common, that's associated with sexual abuse, but it can happen. And that's basically the psychology response of saying, I just want to get done with it as soon as possible and then not think about the sexual space again, and then I can feel safe. Delayed ejaculation is a little bit like anorgasmia, in a way that if the trauma was also something to do with an ejaculation, people can just delay the ejaculation and sometimes feel impossible to ejaculate because that's avoiding the trauma as well. Anodyspareunia is one that's not really talked about a lot, but it's like dyspareunia, but for the anus. And so that could be a memory of pain that happened in the anus if the sexual trauma happened in the anus, or it could be that anytime someone goes anywhere in the anus, that person is going to feel the pain or anticipation of the pain or not wanting anyone to go near there because trauma happened in that area in the past. And of course, you've got all the relational issues that comes with sexual abuse, avoiding sex, creating arguments just before sex so that sex doesn't happen, or withdrawing from the conversation or checking out so to make sure that sex doesn't happen. All those things are strategies to mitigate the stress and the post-trauma reactions that's to do with the erotic space. And for most people that have been sexually abused, of course, they will have internalized some core beliefs like I'm unloved, I'm unwanted, I'm disgusted, I'm wrong. And all of those things, you know, especially I'm disgusting or I'm disgusted, you know, if people have those kind of core beliefs, the body is going to react accordingly. And that's not going to be a good preparation for an erotic system to function very well. So the trauma treatment protocol is the three-phase protocol. Phase one is stabilization and safety. So that's basically helping the client get lots and lots and lots of emotional regulation so that they can reduce the flashback, the dissociation, or all of the unpleasant symptoms of the post-trauma stress. And that's the most important phase, helping clients get some resources to manage the emotions and manage the distress, very important. Phase two is reprocessing the trauma if that needs to happen. So that means getting the trauma story in the past and not confusing with the here and now. And integration is more of an existential phase of people just getting a new sense of self with the story, the life story that they've had, and making sense of it all. What I'd like you to remember from this presentation, if there's one thing to remember, is that stabilization and safety has to be done before any trauma processing. That's really, really important. So just think of the Coke bottle. The trauma is really shaking the Coke bottle very much. If you're going to open the Coke bottle straight away, it just spills all over, and that's re-traumatization, the trauma spilling everywhere. You must avoid that at all costs. What's important is to not talk about the trauma until you're absolutely sure that your patient or your client has enough stabilization strategies. And sometimes that's all clients need, stabilization strategies, and then somehow trauma gets resolved without even talking about it. That is the most important thing. We might want to talk also about the will of consent. That's Betty Martin exercises. That's very good. She's got a website. You can go on and get some 3 minutes exercise. That's very good about learning or teaching your clients the idea of touch, how to touch somebody and how to get touched in the 4 quadrants of the will of consent. So I'm just going to go there very briefly because of time, but those exercises are usually very, very good for people with past sexual abuse, and they really get on with starting to enjoy touch again through that process. But it's a very slow process, and clients really need to just take their time with that. Very important. And of course, then you've got some traditional sex therapy treatment that's very good for people, but you can do that after you have reduced the post-trauma stress symptoms. And when you have done a lot of will of consent exercises, then you can get on and do some sex therapy treatment like sensate focus, waxing and waning for erections, stop and start for rapid ejaculation. Visualization is a really good one for people with vaginas that have been sexually abused. You can get them to enter their vagina and go inside and redecorate the inside of the vagina. And sometimes that can be really, really healing to do these kind of exercises. Dilators, I don't really recommend it to launch into dilator use straight away. It can be helpful with sunset focus, but sometimes it's not necessary. And of course, for people that have relational issues with core beliefs, with trying to sabotage their relationship so that sex doesn't happen, sometimes couple therapy or relationship therapy can be helpful. And of course, at the very end, what you're aspiring for when you work with people with sexual abuse is Kunsikkuroi, and that means, as you can see on the picture, it's the existential place, the integration, the phase 3, when you get clients and patients to really talk about how after all of their life adversities, they have ended up as a much better article than the original one. So a vase can be beautiful, but when it gets broken, if you enhance the breaks with gold, then the vase becomes even more beautiful. And I think that's a really good kind of image for what healing looks like after sexual abuse. That's all for me. If you want to connect with me, you can contact me through my website, and you can also follow me on Twitter, Instagram, and Facebook. I tend to post some stuff about trauma and sex and relationship related stuff. So feel free to follow me. Thank you.
Thank you so much, Silva, for your presentation. Now, Giovanni, you can start sharing your screen. Open your microphone. The floor is yours.
Can you see it?
Yes, please put it in the presentation mode.
Okay.
That's perfect.
Thank you. And thank you for your presentation, and thank you to the ESSM for giving us this opportunity to share our clinical and also empirical experience in the field of consequences of sexual abuse. So here is my financial disclosure. I thank Professor Neves for already giving us all the information that we need. I just want to stress that what we consider sexual abuse does not just involve physical violence. It involves also psychological coercion to force a person to engage in a sexual act. And from a psychopathological point of view, what it is important in our in the history of some of our patients is the experience, the subjective experience of unwanted sexual activity. So we know that this is a big issue in our, well, in the Western society, but of course not just in our society. Well, we have a huge rate of sexual abuse, not just in women, but also in men across their life in our society. So which are the consequences of sexual abuse? Just going to try to integrate what Silva already said in his wonderful presentation. Well, before going into numbers, I basically want to show our research activity. I just want to start with the script of one of our patients with reporting eating disorders, the script about her sexual activity with her partner. She was a victim of a sexual violence many years before this script. She said, we have sex almost every day, so it is not true that after sexual abuse, people do not want to have sex, but it is something more complex that we can think. She said, sometimes we begin having sex, but I'm not even excited. In the middle of the intercourse, I suddenly feel a strange and fearing sensation. I see the scene from above. My body shaking during sex. I perceive a growing feeling of anxiety and pain. At this point, I just want him to finish as soon as possible. So in this script, you can find sexual dysfunctions, of course, but also some psychopathological dimensions, which are very important to explain these sexual dysfunctions in victims of sexual abuse, such as depersonalization and dissociation during sexual activity, and also the matter of emotion dysregulation. So first of all, history of trauma, especially history of trauma during adolescence, means complexity. Complexity from different perspectives, complexity of symptoms and complexity of clusters of symptoms. So complexity of diagnosis. We see that victims of sexual abuse often report the so-called comorbidity of different psychiatric diagnoses and different problems. So which are the common features of all these comorbid conditions? So first of all, to think about sexuality of victims of sexual abuse, we should think that sexual health is not just the absence of sexuality or not just absence of sexual dysfunctions. Sexual health is a balance between physical, emotional, mental, and social features which are related to sexuality. And it is a balance that is structured across adolescence and even before between interpersonal schemas, embodiment, and emotion regulation. And childhood sexual abuse impact on most of the times on all these features. So the literature generally think about consequences of sexual abuse in the sense of hypofunction, so the so-called sexual dysfunctions, but also this is a promising field of research, the so-called hyperactive sexuality and uncontrolled sexuality. And body uneasiness, emotion dysregulation, dissociation, so detachment between mind and body are in some way mediators of this outcome in the long term. Sexual dysfunctions means, as Silva already said, sexual dysfunctions, gynecological problems, vaginismus, and sex avoidance. In this study that we performed some years ago, we simply assessed persons attending the gynecological service, and what we found was that people reporting unwanted sexual experience in their life reported low orgasm function, and this problem connected with orgasm, which Silva already spoke about that. It was deeply connected with the problems with body and body uneasiness. And this problem was even more prevalent and even more strong in if the abuse was during adolescence. So according to the self-trauma model, a sexual abuse occurring during adolescence impact on expectations and assumptions about relationship. So people perceived a different way of being with the others and a different way of evaluating internal states and impacting on a sense of identity and on emotion regulation. People victim of abuse report more negative sexual self-concept as the other persons. So negative feelings during sex, less sexual satisfaction, greater sexual anxiety. But of course, the interaction between abuse and sexual satisfaction is not just mediated by the anxiety or depression. We know that we notice from our clinical experience and also from empirical experience that there is a kind of disconnection between mind and body. For example, women with a history of abuse have a weaker vaginal response to sexual stimuli compared to women without sexual abuse, or women with sexual abuse show a weaker response as compared to those without sexual abuse. What about hypersexuality or uncontrolled sexuality in victims of sexual abuse? We know that some persons who are victims of sexual abuse often report teenager pregnancies, larger number of sexual partner, extramarital affairs, high frequency of unprotected sex, use of drug during sex. So a lot of problematic behaviors connected with their sexual activity. But which are the mechanisms that underlie this uncontrolled sexuality? Well, for example, interpersonal schemas should be considered. For example, the concept of traumatic sexualization, which refers to the development of precocious and negative feelings and attitudes about sexuality that result from a child being rewarded for engaging in sexual activity and sexual behaviors that are inappropriate in regard to his or her developmental level. So in other words, there is a kind of over-sexualization of the relationship of these persons. So they look for care sometimes, think about people who were raped by their caregiver, and they look for this, they look for attachment and interaction by means of a kind of over-sexualization of their interaction. In this study that we performed some years ago, we found that paraphilic behaviors in women, in students from the general population were, for example, associated with history of sexual abuse. So a kind of uncontrolled sexual behaviors, ego-dystonic sexual behavior was associated with the history of sexual abuse. In this study that we performed in anorexia nervosa and bulimia nervosa patients who often report impulsive behaviors, we found that hypersexuality was present and it was associated with several other impulsive behaviors such as binge eating. And it was also associated with emotion dysregulation. And this particular association was found only in a subgroup of patients reporting history of childhood abuse. So the idea, according to with the literature, is that regardless of the diagnosis, people with sexual abuse are a specific subgroup of persons with specific psychopathological features. In this study, performed some years ago by Mesmer Moore, they found, for example, that the explanation of the phenomenon of victimization, so the association between childhood sexual abuse, risky sexual behavior, could be explained by emotion dysregulation, the inability to manage emotions. But sexual trauma means also biological complexity. We do not have to think about just one neurobiological system. Of course, that the HPA axis is connected with emotion regulation. But of course, that there are other systems which are interconnected with emotion regulation. For example, the reward system, which is also important and which is also should be studied and maybe targeted with pharmacological treatment. Because we know that emotion dysregulation is also connected with reward and not just with HPA functioning. We know in the script from our patient and from our clinical experience that sometimes sex is perceived with fear. In these studies that we performed some years ago, we look at the interaction between impulsive behaviors, the fearing sensation of dissociation during sex, the perception of one's own body, and the stress response. In a general population of students, again, we look at, we studied this population with a task in which persons just have to look at the sexual stimulus, and during the stimulus, we assessed salivary cortisol. So the HPA axis functioning, the system which is mostly associated with the emotion dysregulation according to several research papers. And what we found was that people reporting high dissociation during sexual intercourse showed a kind of paradoxical activation of HPA axis. And the same was found for persons reporting binge eating. Again, a paradoxical activation of the system of fear, the system of the flight-fight reactions, but in this time in response to a sexual stimulus. So we attempted to replicate this data on, again, on anorexia nervosa and bulimia nervosa patients because this is my clinical experience and because we know that in anorexia nervosa and bulimia nervosa persons, there is a lot of sexual violence in their history. And what we found again was an association between cortisol and desire. But this specific association was only found in persons with a history of sexual abuse. So how we can explain this first result in their complexity, paradoxical complexity, where our explanation was that women have been abused, the emotional involvement in sexual relationship sometimes would result in activation of the mechanism of stress. So a paradoxical activation of mechanism of stress, which in many times is unconscious and which can account for some of sexual dysfunctions. How we can consider also the reward mechanism? Well, in the study that I was mentioning before, in which hypersexuality was found to be associated with other impulsive behaviors in persons with eating disorders, we found that there was a biological marker for these impulsive behaviors, which was not just cortisol, but it was ghrelin. I don't know if you are aware about the function of ghrelin, but what was interesting was that ghrelin was associated with hypersexuality, binge eating, and emotion dysregulation. So a kind of key feature between all these features. Ghrelin was a mediator between the association of the association between sexual abuse and impulsive behaviors concerning eating behaviors and sexual behaviors. Ghrelin is interesting because it is an hormone which is associated with appetite regulation, but it is also associated with reward value of some stimuli. For example, it has been studied in cocaine, substance abuse, alcohol abuse, pathological gambling, and so on. Why reward is important? Because rewarding mechanisms are often used to manage emotions. This is the reason for reward is interesting for alcohol abuse, substance abuse, binge eating, and also, as you can see, in hypersexuality. And most importantly, ghrelin was found to be an hormone associated with PTSD. So people with emotion dysregulation derived from a trauma report higher ghrelin levels. What happened in men, and I'm close to my conclusion, well, there are a few studies about men. As Silva already said, there is a big variety of rates: erectile dysfunction, hyperactive sexual disorder, and premature ejaculation. Moderator and mediator are less studied as compared to what happened in women for many reasons. In this study that we performed, and which is not submitted, I just want to mention this data because we found very similar results in this study in which childhood sexual abuse in men was associated with body image concern, with hypersexuality, as well as with sexual dysfunction. So don't think about hypofunction and hyperfunction in sexual activity as separate consequences of sexual abuse. They can coexist in the same persons, and they can, so the things are more complex as we can think. Where final remarks about assessment do not focus just on the dysfunction and sexual functioning. Think about the core psychopathological dimensions, as already Professor Neves said: emotion dysregulation, dissociation, body image disturbance. Think about psychopathological complexity and comorbidity, which means more complex strategy in the treatment. And also think that not all the persons after a sexual abuse report sexual dysfunctions, of course. When we think about treatment, we should think that sexual abuse means outcome complexity. In this study, we found, for example, that people with sexual abuse often report a very different outcome to cognitive behavioral therapy. And here is another study that was a confirmation of this data. Here we evaluated the problems with attachment after sexual abuse, and what we found was, again, different response to treatment. Well, use of treatment, pharmacological treatments is quite controversial. There are people who say that it is maybe sometimes is a problem to use this kind of treatment for detachment for dissociation, which can be associated with the use of these treatments. We should think about targeting neurobiological features, neurobiological variables. For example, here just a suggestion: we should think about treatments which are target to, for example, reward mechanism or emotion regulation. And finally, I don't want to mention to go into psychopathological or psychological or cognitive behavioral intervention, because I think that Silva already said about that. I just want to mention mindfulness-based approach, which could be useful in connected body and people after a childhood abuse or sexual abuse. As you can see, they often report dissociation. And I just mentioned eye movement and desensitization and reprocessing, which is also associated to the mechanism that Silva already told in his presentation. So thank you for your attention.
Thank you, both of you, really. Some very, very excellent and very comprehensive talks on this difficult topic, as you're saying. We have a few questions. I think the first one could be for the both of you. So we'd like both of your opinions. How can we ask about sexual abuse in the right way in a situation where it's a patient presenting with sexual dysfunction if the patient does not give us the information beforehand? So we saw in the presentation that pretty much every sexual dysfunction could have a base in this. How would you approach it?
Silva, do you want to start? Or
sure, I can start. It's just asking the question as part of the assessment. Usually I'll be asking something like, has there been any kind of unpleasant sexual behaviors happen in the past, or anything that you perceive as not being right, really? And so quite broad. I don't necessarily start to say have you been raped or have you been sexually abused, but something broader to start with, and depending on the answer of the client, then I might just go and ask extra questions and identify whether there has been sexual abuse or rape or anything like that.
Yes, well, I agree. Of course, it is important is simply ask for. And what I would like to stress to integrate this response is that, for example, in my presentation, I showed you a lot of populations or patients who do not come for a sexual dysfunctions, but they come from binge eating, from eating disorders or other problems, or depression or other problems. And then when they speak about their sexual dysfunction or their paradoxical sexual behaviors, we discover the sexual abuse. And this is a kind of explanation. So sexual dysfunctions is a kind of tip of an iceberg. Then we can discover all these psychopathological features that can explain, for example, the pathological eating behaviors as well as the problems with their sexuality. So this is a recommendation not to stay on the behavior, not to just to treat the behavior or the symptoms, but understand the etiopathogenesis of this problem.
Okay, thank you very much. Next question. I think this was specifically for Silva, but could be answered again with comments from the both of you. Two participants has asked to elaborate a little bit on stage 1 and stage 2, or phase 1 and phase 2 of the treatment, the stability and the processing phase.
Sure, yes. Giovanni actually talked about it. Some phase 1 can be anything to do with emotional regulation. So mindfulness practices can be some of them. It's basically anything that keeps you in the here and now. So it could be breathing exercise, it could be boxing, jogging, mindfulness, all this stuff, really. As many as you can have, from very small little ones like knowing when to drink a glass of water to more sophisticated one like a daily mindfulness practice. Phase 2 as well, Giovanni talked about this. There are many trauma-informed therapies that exist out there that are all very good, like EMDR, for example, or there's trauma-focused CBT, there is DBT, dialectical behavioral therapy, there is schema therapy, quite a few around. There was a meta-analysis that was done on all the trauma therapies, and what was found is that there is not one that is superior to any other. So what it means is that all of them works, and it's really sometimes finding what is going to be working best for the client. So if you work with trauma and you work with sexual abuse, my recommendation is to train in as many trauma methods that you can, so that you have plenty in your toolbox and you can integrate those with your treatment.
Any comments, Giovanni?
Yes, no, I absolutely agree. Well, I think that Silva, well, it is important to think that all these schema therapy, EMDR, trauma-focused therapy, well, they in some way they cover different features, and so I agree that there is no one strategy, but we should train in most of these features and integrate what comes from one strategy to another. What I say is that, for example, do not use just simple cognitive behavioral therapy or simple sexual therapy on a problem of a behavioral problems which has a history of childhood abuse, because the outcome is not good. As you can see, well, the response to available treatments is different. But just one thing, the response to depression, if there is a history of childhood abuse or sexual abuse, is different, even if we consider antidepressant. So think about the complexity of the treatment in this case. Also, different response to pharmacological treatments if there is a history of sexual abuse.
So this is actually underlying the point from before as well, that it's very, very important to ask about these sexual traumas before you start treatment, to not do damage to the patient.
Exactly.
In that same regard, one of the participants is concerned about mindfulness, saying that this participant would be worried that the patient would re-experience the trauma. Is that a risk one should be aware of?
Well, in my opinion, it is an important point because, well, I think that people who are not expert of trauma therapy do not have to work with the trauma, because the risk is to repeat, to speak without any sense about the trauma. And this is something which increase the uneasiness, increase the emotional dysregulation associated with the trauma and the PTSD. What we have to do is to work on the effect of the trauma. So use trauma-specific intervention and then the effect of the trauma. Well, mindfulness in any sense is not associated with the work with the trauma memories. So this is not a problem, because when you do mindfulness, you do not speak about the violence that you had. You work on the, well, of course, is not the, I do not prescribe only mindfulness. I prescribe mindfulness as a part of a treatment. But mindfulness is a good strategy to, or a kind of integration of the psychological intervention to work on dissociation and to embodiment problems. There are evidences also in eating disorders. For example, I do not prescribe mindfulness as a unique therapy for anorexia nervosa, but I can say that if you add mindfulness to cognitive behavioral therapy, this could be useful.
That's right. And I think it's also about being attuned with the clients, because every client are going to have some different responses to their trauma, and people can have multiple somatic markers. And if mindfulness is actually reminding a client about the trauma or a part of a trauma, then just don't do it and do something else, because there's just going to be so many other things we can do. Sometimes we don't know, and the client themselves don't always know what their somatic markers are until they start to try and error with a few things, as long as they just do, you know, bits and pieces, very little, and paste out. And then if something just doesn't agree with somebody, you just change, and that's totally fine.
Right. You know, I think this was repeated in a couple of the comments from the audience, that there is kind of a fear of doing some damage when you start to tackle this topic. And I think, Giovanni, you started out answering the last question, saying that maybe anybody shouldn't just tackle this topic. If you identify that there's been sexual abuse, refer to a specialist. Would you agree?
Yeah, absolutely. Absolutely, because we can damage persons. Well, I have a patient who had a car accident, and his friends were showing the movie of the car accident that they take from somewhere. So the PTSD was growing. They were all medical doctors, and they thought that it was useful for him to look at the car accident a lot of the times. So think about which kind of damage we can do to a person.
Yes, and you know, the trauma therapy is actually a very young field, and the reason why it's a young field that's got created is because of all the mistakes that psychotherapists did before. And so, you know, people like forcing clients to talk about the trauma because, you know, or getting clients to go into some places of catharsis or whatever it is, or exposure, as Giovanni just said. All of this stuff can be really, really traumatic, re-traumatizing, and it doesn't make any sense really once you start to know about trauma. But of course, a lot of people will be fearing of that. What I say is that if you, yes, do train in trauma, definitely if you want to work with traumatized clients, but if you stay first with phase one, when you're not talking about the trauma, you're not trying to reprocess anything before you get proper good emotional regulation in place, then you are less likely to re-traumatize your client. And use your common sense. If a client says, no, I don't want to do that, or I don't agree with that, you know, agree with the client and follow the client's feedback. Because one of the hallmarks of trauma is that clients at the time of trauma, they feel they're not in control of anything. Things are done to them and they cannot control what's happening to them. So you don't want to replicate that in the therapy room. You don't want to be the expert that's going to do something to the client with that client's consent. That would be re-traumatizing as well. So do use your common sense as well.
Thank you. Excellent. And a wonderful, very important comment to end this session with. It's 9 o'clock, so we're done. It was great to have two experts. I started out by saying it. I was reinforced in this opinion, really two world experts. And thank you for excellent talks. The compliments are coming in the chat box. And I have to ask all of the audience to, before you leave the session, do fill out the evaluation form so we can see your opinion of the session. So thank you, everybody. Thank you very much to the speakers. Thank you to IBSA, and thank you to the audience for being with us tonight.
Bye-bye. Have a good night.
Bye. Thank you.
Thank you so much, everybody. Have a nice summer. Bye-bye.